Hi class, this is Dr. Cilio, and today we are talking about behavior change and global health interventions. Learning objectives, briefly, we're thinking about theories of behavior change and some measures that are commonly used in global health to improve health and health behaviors. We'll also talk a bit about the relationship on expenditures and health, as well as review the use of cost-effective analysis as a tool in deciding which health programs we should scale up, which is commonly used in global health. So I think we are ready. We've really come to the conclusion and come to learn that risk factors that are the leading causes of diseases in all countries often come down to health behaviors. So when I refer to health behaviors, I'm talking about, our lifestyle, what we eat, whether we smoke, whether we have unsafe sex or sex with multiple partners, hygiene behavior, like washing hands, drinking alcohol. All of these are considered health behaviors. And as hopefully the textbook and the previous lecture highlighted, these are also related to culture. And this is why this topic is paired, in the same week and in your textbook under the topic of culture. What we eat, how we behave very much is linked to the cultural norms and the environment that we live. We can improve the health of populations, then, of course, is very much tied to helping populations improve their health behaviors. And so a big question in public health, in global health, in social and behavioral sciences generally that are related to health is how can we help people change unhealthy behaviors or adopt healthy behaviors? And it's important, I think, to think about, that we study these behaviors because they're associated with health. It's not a judgment, and we don't really, in public health, attribute anyone's personal, moral character to their engagement in what we call quote unquote unhealthy behaviors. But we know from our scientific evidence that these are actually linked to poor health outcomes, and that's why we're interested in changing them. So today we're talking about health behavior models and frameworks, also referred to as theories of behavior change. We're going to talk about two major theories that are commonly used in global health and public health. I think it's important for me to first just define, what are we talking about when we say theoretical models and frameworks? Essentially, it is an attempt to create a model or a framework or a map, so to speak, that helps us understand the factors that influence someone's behavior. So someone's, decision to engage in a behavior or not, sometimes they're very much based in psychology, and we'll see that with like the help belief model or even the stages of change model, which is very much about like the cognitive process that people go through, the thought process, their understanding of a health problem and things like that, and how that influences our behavior. Others, like the ecological model, very much is similar to our social behavioral determinants of health model, which is really thinking about how not just the individual and their thought processes, but the broader environment influences their health behavior. The reason we're interested in these is, if we can understand what is a determining factor, what contributes to a health behavior, then we can create programs that aim to target the components of these theories and then thus reduce that unhealthy behavior. So These models are heavily researched. People do a lot of studies to try and confirm and build on them and create them, and they should really come out of research, and regardless, research should be used to sort of understand, do these really predict behavior, and then that sort of helps to validate them. Overall, it's generally agreed on that public health and global health programs are more effective when they're theory grounded or theory based. So if we don't just start from nowhere, but start from a model that's been studied and tested and has been shown predictive of behavior, that's going to be a better start for building a health program than no basis. So the ecological perspective, or sometimes called the social ecological model, I think this will be familiar to you because it very much aligns with the social determinants of health perspective that we've already been talking about. So it's basically this idea that our health at the individual level, our behaviors, is determined by multiple factors across these levels here, and those factors interact to influence health. So it's very much this idea that we need to think outside of just the individual and think about social environments and how they shape behavior. This is from your book, and it just gives a definition of each of these levels. You can review this more closely as you do the reading, but I'll give you more of an illustrative example here. So this is sort of the model applied to the occurrence of violence against women. So I think it's important, to think about this, that these models do two things. One is they help explain behavior, and then later they can be used to applied to change behavior. So in this case, this health model is being used to explain behavior. What are the things that contribute to violence against women? The individual level attitudes and beliefs that support sexual violence. I think this is specific to sexual violence, by the way. So attitudes and belief, this is talking about a person who would be a perpetrator. Attitudes and beliefs that support sexual violence, impulsive and antisocial behavior, a childhood history of violence or witnessing violence, as well as alcohol and drug use. So these are influences at the individual level within a single person that would make them more likely to engage in violence against women. Relationship level, association with sexually aggressive peers, a family environment that's emotionally unsupportive or physically violent, or strongly patriarchal, which would be more likely to endorse sort of the idea that men are superior to women and should dominate women. So already you can see how these factors would interact, right? This is an important component of this model, the interaction across levels. So let's say you have a person with a history of sexual abuse. Maybe a better example would be someone who's engaging in alcohol use or heavy drug use, and then is also in some type of emotionally unhealthy environment. Those two factors could interact to make that person more likely to be violent. So they might be in that environment, increases the risk of violence, but without maybe that alcohol use, it might not, progress. So this is an example of the interaction. And the trickle down is really important. So if you are in this family environment that's emotionally unsupportive, or patriarchal or physically abusive, that is associated with individual attitudes that might support violence themselves because they're raised and socialized in that environment. The community level, this would be general tolerance of sexual assault. This would be, that it's maybe normalized, it's viewed as something that happens behind closed doors and is a personal issue that families should deal with, and that the legal system should not. Lack of support from police or the judicial system is another example of that. Poverty, a lack of employment opportunities, weak community sanctions against perpetrators. So this at the community level creating a social environment where these things happen and there is no consequences. At the societal level, of course, this is all driven by just broader inequities between gender, race, sexual orientation, etc., as well as economic and social policies and cultural norms. So in some societies, it still is viewed as acceptable for a man to hit his wife if she steps out of line, right? And this is a cultural norm. So then in that norm, in that normative environment, you're more likely then to see all these kind of factors trickle down. But as I said before, it really should be research that's driving the inclusion of these factors at each level. And that's important, that this is not, made up, but it's based on the collected evidence from the literature of all of the research on violence against women, and then it can be organized in this model to help us see how the factors relate to one another. Now, this is also talking about violence against women. In this, it's specific to intimate partner violence. But here is showing how we can use the same model, this social ecological model, and think about multi-level interventions, which I use basically as a term for health programs, to change behavior. So if we know what factors are driving violence at these different levels, then we can create programs that target change at those different levels. So at an individual level, this could be trying to change people's attitudes, working one-on-one with people, maybe with people who have been convicted of violence against women, perpetrators who have been arrested and have a history of it, and actually trying to do counseling and one-on-one sessions with them to change those attitudes and improve their value of healthy relationships. This can be also done, an intervention at the relationship level. So people within a couple, you have a couple maybe with a history of violence, trying to give that couple skills to resolve conflicts, to manage emotions, to respect each other's autonomy. This is something in Uganda we do for our family planning intervention, where we have an intervention that specifically engages men and women as couples. And it talks about sort of what is a healthy relationship, why is a healthy relationship important to sort of economic, physical, and emotional health. How can we get more skills about how to communicate with our partner in ways that doesn't increase violence? And we do this in the context of family planning because we find that relationships for women in the setting that we work, that their family planning access is very much driven by their male partner's approval, but communication about making decisions around reproductive health is really prohibited by sort of a lack of healthy relationships and skills around communication. So that's what we aim in our intervention to target. At the community level, there's things called bystander prevention strategies, or basically partnering with different groups in different sectors like the police or schools. You can start this work as early as middle school and talking about what is a healthy relationship. And at the societal level, it's really going to be kind of about policies and laws that would change those other factors that we talked about earlier, like there not being any support in the criminal justice system for persecuting people who engage in intimate partner violence. So hopefully this is clear how we can use the model to understand the behavior and then use it to make a program that targets those specific determinants of the behavior. And I think this model is really, really useful. I use it in my own work, and it's very, very popular in global health and public health because really, I think, helps us conceptualize like what is it we're trying to change and create a program that is multi-level, because it will just be more impactful because of those interactions, right? So those interactions, that trickle down effect. So the health belief model is another one. And when I said some are really based a little bit more like psychological, cognitive, this is one of them. This is based in psychology and one of the earlier ones that was adopted when health behavior theories kind of took off. Basically, it's much more about like the thinking process that a person goes through and the knowledge that they have and the skills that they have to engage in a healthy behavior. So it basically proposes that people's health behavior depends on how much they think they're likely to get an illness, how severe they think the illness is, the benefits of engaging in behaviors that prevent the illness, and the barriers of engaging in preventative behaviors. So I think a good example is COVID, you know, whether we mask, whether we social distance, whether we get the vaccine, these are all health behaviors related to COVID prevention. And whether we do that really depends on how contagious do we think it is. You know, that might even be based on community transmission rates and might vary over time. How severe we think the illness is, whereas, you know, a year ago, 2 years ago, we were more worried about the severity because of the great number of deaths that were happening. And as it's progressed in variants and through vaccination, maybe we're a little bit less worried about the severity. You know, but if you have an underlying condition, that might be different, right? So these are the thought processes that go into, you know, the likelihood of you getting it, the severity of getting it, the benefits of engaging in the behavior, like, well, I don't really believe that masks do that much, or maybe you do. These are that sort of cost benefit weighing that happens in the health belief model. And then barriers to engaging in the preventative behavior. This can be, you know, pretty much anything that makes it difficult to do. You know, I mean, even just discomfort of wearing a mask, or maybe the fact that nobody in your social group does, and then you would be the only person doing it. This might be a barrier to you deciding to do that. The other piece of this is self-efficacy, and this basically is, I think, the best way to describe it is your confidence in being able to do the behavior, whether or not you feel you can carry out the behavior. So wearing a mask is quite simple. It's not like a skilled thing. We can put it on and it's not complicated. But there are some other complicated, maybe more complicated health behaviors like exercising that we kind of need to build skills around and confidence, or cooking healthy meals, even using a condom. You know, these things take, you know, basically learning the skill. And so a health program, let me see if my next slide. Yeah, a health program that wants to change these behaviors that we're talking about, whether it's condom use or mask wearing, would develop content that specifically aims to increase people's awareness of the severity of the disease, their risk of getting it, because you know, we're all humans. We don't necessarily know the accurate information of these things. Something like HIV, for example, people might feel that they're at really low risk because they don't know anyone with it, or they make false assumptions of what the type of person who has it is like, and that's not necessarily true. It might be based on stereotypes. And so, you know, making people aware that they are at risk like anyone else can increase their likelihood. And then the self-efficacy piece is really about giving people skills. So if it was condom use, it would be showing them how to use a condom. And that might seem silly because, you know, I don't know. I'll say in New Jersey, we learned that early in I guess as early as high school. It might be different here in Texas. But in other settings, it might not be that accessible and might not be common knowledge, and people might need in a health program for that to be something that's taught. So this is just an application of of the health belief model, and not on the other side were these cues to action. And these are also part of the model that basically says that cues in our environment will also increase our likelihood to engage in a behavior. And this is very much something that can be integrated into a health program. So, reminders, for example, like if the health behavior you want to improve is like diabetes management or adherence to, HIV medication that you have to take every day, like a simple tool that like an alarm that people set to remind themselves that they have to take that pill is a cue to action. Even like a pamphlet or a picture in the doctor's office where there's like, information about the HPV vaccine, that's a cue to action for the doctor to talk about the health behavior with the patient, or for the patient to ask about it. So the stages of change model, this is also called the trans-theoretical model. Model that basically thinks about change as a process, and that in any given time, any individual person is at a different stage in being ready to change their behavior. This was developed out of addictive behaviors like smoking, drinking, and drug use. And you can kind of see that, I think, when you look at the stages of change, because, we know that with addiction, a person really needs to sort of be ready to make the decision to change. And there's these other pieces like relapse, something like falling back into the negative behavior is, of course, very much aligns with like addiction behaviors. But basically, it's sort of developed as this thought that, you can't just have a health program that, gives everyone the same content without really thinking about where are they in their readiness to change. And they have these different stages, like pre-contemplation. They don't have any intention to start to change their behavior. Maybe they're starting to think about it, would be contemplation, and they move all the way to action and then maintenance. This is just a visual that kind of shows that for like exercising and eating healthy. You can just take a look at it, contemplation, or pre-contemplation, then contemplation, where, he's thinking about, what are the behaviors I could adopt, preparation, like trying to learn about how you can do it, action, and then maintenance, making it part of your regular routine, and then relapse, you have to excuse the dramatic sort of, relapsing on a hamburger. Let's not stigmatize eating, normal food and everything, everything in moderation. But this is just a visual cue to get us to understand the concept. Finally, diffusion of innovations model. This is a model that tries to understand how an innovation, which can be a health program or health behavior even, is sort of communicated over a population and then adopted. This comes out of, it's been used really widely in marketing, research, and all sorts of research. And you can see that it basically proposes that any innovation kind of follows, in terms of how it diffuses across the population, it follows like this this bell curve of that there's like 2.5% of the population that are innovators, the first to do it, then early adopters, the early majority, the late majority, and the laggards. Something like technology, like the iPhone, which nobody used to have, and now everyone has. This is sort of how it would diffuse over time in this model. And I was a laggard, actually. But it's also influenced by perceived benefits, the fit with the cultural values, the ease of trying it. This is all about the innovation. role models and perceived cost effectiveness. So, some overlap with our earlier models. I mean, basically understanding behaviors, it requires like this assessment of of what's happening, um, whether or not these behaviors are going to be harming health or hurting health, why people engage in them, and then the likely response to different approaches to changing that unhealthy behavior. And so, I mean, this is sort of thinking about like that starting point of a health program and how we create, a program that will respond to this. And, if you know this information, you can then think about the health behavior model that might be most effective. So your book talks about a number of different intervention approaches or strategies to changing health behaviors. Now, you could link these to the models earlier, but these are, not necessarily like tied to that, but just sort of approaches that are widely used. Using mobilization, this is really important, especially in areas where there's not like widely disseminated, television programs or, messaging that you might receive and get via like technology. So this is really trying to engage an entire community in identifying the problems and promoting healthy behavior themselves. And so community dialogues is one way that people do that. You can look at the link when you go through these slides. But it's important also to have leaders in the community who would champion this change. And this is actually the approach, this community dialogue approach is a big part of what we do to promote family planning in the communities we work in Uganda. And I think I have some lecture in the future where I'll talk about that intervention more specifically. But the important part of this is it's trying to reach a wide group of people, but it's also trying to use the community directly as the agents of change and empower them to make the change in the community, a more sustainable approach. Mass media, of course, this can be in a number, it can be via television, and researchers have been trying to do things sort of in an innovative way, like with text messaging interventions and social media. The Truth Campaign is a really, big one that I think a lot of us are familiar with in terms of, kind of creating broad awareness about the harms of cigarettes and tobacco smoking. Even like these comic books, for example, is another approach. If you get a chance, take a look at the link. The soap opera is a soap opera popular in South Africa that teaches about HIV prevention. And yeah, it's pretty interesting. So social media, of course, this is something that, is fairly new in terms of being adopted by health programs. But as you can see here, even the Texas Department of State and Human Health Services, using it as a platform to promote knowledge around the COVID vaccine. But maybe even more so than this is that social media has the ability to allow people to engage in the behavior, in the content more than what would maybe have been previously done in mass media. So, for example, being able to comment, being able to actually communicate with the program leaders and things like that via social media. And we know that it's an effective way to spread information, but also misinformation. And so that's definitely a risk to global health and public health, which we have seen throughout the COVID pandemic with a lot of conspiracies that have become elevated because of social media. Finally, social marketing. I don't know why I said finally, it might not be finally. Social marketing is a tool used in commercial marketing that researchers and programmers have tried to say, we're so good at marketing products, right? We can, here in the United States, especially, I mean, the amount of skill and talent that is in sort of the advertising world and in companies that sell us things is, amazing. We watch a commercial, we want that, right? Social media becoming, maybe even more important in terms of that. So health programs have said we need to sort of think about how commercial marketing is so successful and bring that into our interventions to change behavior. And some principles as part of that is the 4 Ps. But the product needs to be attractive, it needs to be affordable, it needs to be convenient, and it needs persuasive promotion. That's simple to say, but maybe harder to do. Still can learn lessons from this. Health education as a category is just as it sounds. It can be, in a classroom setting. It can be through those other venues that we talked about, like mass media. But it really needs to be providing accurate information, easy to understand. It should engage stakeholders, people that are leaders in the community, to increase sort of the knowledge dissemination. And it should be targeted to the group that you are sharing it with. So, I can't just take a family planning education program that we've done here in the US and try to bring it to Uganda without adapting it to the local context, setting, and everything else, or it won't be understood, nor will it be well received. This is just an example of some innovative ways where health education has been integrated into sort of central places of communities where people gather. This is an example of a program that used barbershops as a way to disseminate health education. Other programs very intentionally engage faith-based organizations. So, having community leaders in a church or in a mosque, at any religion, they have big sway and a big influence on the attitudes and norms of a community, because they're well respected. And so getting them to sort of champion a program or be, the sort of the educator themselves, it can be a very successful approach. Conditional cash transfers, also unconditional cash transfers. That's why I have and not. This is basically when a government agency provides an incentive, an economic incentive for families who engage in a healthy behavior, and that's when it would be conditional. So giving birth in a hospital, or participating in a nutrition program, or a child care program, some governments will make these incentivized. So I'll show you an example next, but they can also be unconditional, where there is no you don't have to prove that you engaged in the behavior, but there can be economic incentives from governments in recognition that overall will improve the health and well-being of populations. Prospera is Mexico's conditional cash transfer program, which has been around for a long time. And it, it's not across the population, but it might be with, the most at-risk population, the most vulnerable and most impoverished communities, but it would give money for sending kids to school or going to the health facility or giving birth in a with a skilled birth attendant. And there's been lots of evaluations on this in terms of, well, how has this impacted population health and development, and a lot of positive outcomes of those evaluations, increasing school enrollment, improving child nutrition, and other maternal and health outcomes. And this is viewed as an important investment from the government. You're giving out money, which is a cost, but what is the benefits? What's the payback? Reducing maternal morbidity and mortality, improving education enrollment. All of these things actually have benefits for the growth, the economic growth of a country. But unconditional or non-conditional cash transfers don't require any specific action. And this is a debate in global health, and there's different philosophies behind each. Do we need to incentivize people? Do we need people to, show that they did it, or will people with money given to them, people in poverty, will they use it to improve their social and health outcomes? And people have evaluated that too, and have shown that it's has had positive impacts of increasing school enrollment, child nutrition. That belief that people will use it irresponsibly, right, is sort of why people would be against this. But I think by and large that would be a minority, and overall the benefits would still be quite positive. And people, it's about kind of believing that people can be the agents of their own lives and will make decisions that are best for themselves and their family. Social assessment is the process of assessing the social impacts of a planned intervention and developing strategies for the ongoing and monitoring and management of those impacts. It's basically about thinking about, the impacts of a program beyond just health. We're thinking about this conditional and unconditional cash transfers as improving not just health, but also these other social outcomes: child labor, school, nutrition, etc. When it comes to how much money, countries spend, and then the sort of spend on healthcare, and then the sort of the benefits they get from that in terms of life expectancy or health outcomes. This graph is showing us life expectancy at birth against the total expenditure on health as a percentage of the gross domestic product. And I think, by and large, most high-income countries spend more on health and have higher life expectancies, whereas low-income countries spend less on health and have lower life expectancies. And this is, of course, just a correlation, but still, of course, it makes sense. But there are some outliers that trying to see graph. There are outliers like Sri Lanka and Cuba that spend relatively little but have higher life expectancies. And this, Cuba is hailed as a model for public health because they actually do a lot around prevention, and that has been, that's why you see, more life expectancy for less cost. The last concept to talk about is cost effectiveness of health interventions. It's basically comparing the cost of an intervention with the amount of health that can be purchased with that intervention, right? So it's important to think about because it can help set priorities in global health, and really help us make decisions about where we should spend our money. What are we going to get sort of the best return on our investment? This shouldn't be the only factor in decisions, but it's one important one. Of course, when we have not a lot of money to spend usually anyway towards health. You know, how do we make those decisions? This is how it's calculated. I think probably not totally important for you to know that, but it's there if you're interested. Using dailies averted per dollar spent is essentially that. And then WHO Choice is a group that is from the WHO that basically are leaders in doing cost-effective analyses and making that data sort of publicly available, so health programs and governments can access that information. A related concept is cost-benefit analysis, which assigns monetary value to all expected costs and benefits of an investment. It compares the net present value and future accrued benefits. And it's basically about sort of the benefit to cost ratio. I think this last point is important in terms of really understanding sort of the core difference and similarity. They both include health outcomes, but cost benefit analysis places a monetary value on health outcomes, so that costs and benefits are in monetary units such as dollars. Okay, so that is the lecture. Thanks for listening, and you can write on the discussion board Q&A if you have any specific questions, or of course bring them to class when we meet again. Thanks.